is mainly mediated by
Yeah.
is mainly mediated by EPO. So the thing is, now as you notice that plasma volume increases by 50%, but red cell mass has increased only by 30%. So in effect, there is a net dilutional anemia. Now we have a overloaded system. So to compensate for this, there's an increase in cardiac output.
Okay.
Cardiac output increases by up to 50% at by the end of term. This is mediated mainly by
Yeah. Go ahead.
it's mediated mainly by an increase in stroke volume and heart rate.
Okay.
Can I draw a graph to show it, or you want?
Definitely. Yes.
Am I visible? Because I can't see my video. So
Yeah.
am I visible, sir?
I can see you.
Yeah, I'll just draw it.
You just draw it and show me at the end of your diagram.
Okay. So yeah, as I told you, 40 weeks, and this is percentage change. I'm drawing on x-axis the number of weeks of pregnancy, and on y-axis I'm making a percentage change. By 24th week, it reaches up to almost 50% and remains at that level, the cardiac output till the end of term. The heart rate and the stroke volume increases by approximately 30%, and heart rate increases by approximately 25%.
Okay.
Now we need to understand that just during onset of labor, there's further increase of 45%, and during third stage of labor, that is when the baby's delivery has happened, because of uteroplacental transfusion, there is actually an increase of 80% cardiac output transiently, and all this cardiac output returns to normal.
Okay.
I'm sorry, it's not a very proper diagram.
So what are changes in respiratory system?
Okay, so respiratory system, basically what happens is, first of all, oxygen consumption increases, and it increases by up to 50%. Now, to compensate for this, there is an increase in the minute volume. Oxygen consumption increases by almost 60%. Minute volume increases by approximately 50%. Now, in pregnancy, the minute volume increases mainly by increase in tidal volume.
Okay.
There is also an increase in respiratory rate. Then now, because of the gravid uterus pushing upwards, there is a decrease in FRC, and this is encroaching upon the closing volume. So there is a high chance of V by Q mismatch, that is ventilation perfusion mismatch, and especially in supine position. Then
so what is the percentage you expect the drop in FRC?
So around 25% drop in FRC takes place.
So you can say like in supine and in supine how much?
I'm not sure about that.
Yes. Okay. Go ahead.
Then okay, so as I mentioned now, because I said there's increased production of CO2 and there is a hyperventilation tendency to hyperventilate. There is actually the PCO2 decreases. The PCO2 decreases, and because of this, there's the pH decreases by almost 0.04. Now, this will make us feel that there is actually respiratory alkalosis, but and this would actually hamper oxygen delivery. But because of a compensatory increase in 2,3-DPG, that is maternal 2,3-DPG, it favors unloading of oxygen. I mean, net effect is seen that it favors unloading. Now, anatomical changes in respiratory system is that we know because of increased laryngeal edema and capillary edema, it becomes kind of a difficult airway. There's increased breast mass as well. And
okay, Abhinav, excellent. So, okay, any other than these volunteers want to participate now for other systems?
Yes,
You want me to?
I would like.
No, I will come to you people later. Any
Yeah.
other than these three? Anyone wants to say for other system changes?
Yes, sir, I will.
No, I'll come to you later. Any other, like those who have exams in March or they want to participate now,
Okay.
can raise your, or you can unmute yourself. What are the hematological changes you expect in pregnancy? Anyone?
Sir, I would like to do it, sir.
Who is that? Can you unmute yourself?
Yes. Sir, Indumati.
Okay. So, okay, Indumati Karthik. Good. Very good.
Yes, sir.
Okay. So how are you? Where are you
I'm
from?
fine, sir. I'm from Chennai, sir.
Okay, very good. So can go ahead.
Okay.
So what are the changes in hematological changes?
Hematological changes, there is an increase in the RBC volume by around 20%. And there is also increase in the WBC count. There is also increase in fibrinogen and all the clotting factors except clotting factor 11 and 13, sir. So it's more of a
Very good.
procoagulant state. Pregnancy
Okay.
is more of a procoagulant state. And the dilutional anemia which results helps in good uteroplacental flow also.
Okay.
And there is even though there is increase in the platelet production, there may be sometimes decreased platelet count.
Okay.
This may be due to increased consumption.
Okay.
And even though there are it is a procoagulant state, the tests of coagulations are usually normal in pregnancy.
Yeah.
um and
Yeah. So
after that,
almost you have said everything. RBC volume increases. And coming to coagulation, all coagulation factors increase except factor 11 and factor 13. Okay. And there will be fibrinolysis and
yes,
thrombocytopenia. Okay.
yes, sir.
Excellent. So you want to go tell more, or you can tell GIT changes?
Yes, sir. GIT changes. So actually, there is in the GIT, there is a cephalid displacement of the gut contents and the liver because of the mechanical effect of the enlarged uterus, sir. So because of that, the intragastric pressure, it increases and the lower esophageal pressure decreases. So the net pressure, it decreases. So there is a likelihood of reflux in pregnancy.
So increased risk of aspiration in pregnancy because
As
of increased
increased intragastric pressure
and decreased
and
barrier pressure.
decreased barrier pressure.
Yeah.
Yes, sir.
Very
Decreased.
good.
So the barrier pressure decreases.
Yeah.
And the low esophageal sphincter pressure decreases
Decreases.
mainly because of the effect of progesterone.
Yeah.
And there is also delayed gastric emptying, sir. So we treat any pregnant patient, however long they have been nilparoral, we take them as only to be full stomach.
No, but at what stage of pregnancy you expect delay in gastric emptying time?
After 20 weeks, sir.
Sure.
I'm not so sure about this. I think it is 20 weeks.
Yeah, so gastric emptying time increases only during labor, not throughout the pregnancy. Okay.
Okay, sir.
And also in a patient, so those are received the opioids in any form like either IV or a subarachnoid or a epidural. Plus during labor, and because of labor pain, anxiety, these all three things will increase the gastric emptying time. Not other time. Okay. Now other time there is a risk of aspiration because of whatever you told, right? The gastric barrier pressure decrease and decrease the LES tone. So those are the things.
Okay, sir. Okay.
Excellent, Indumati. So
Yes, sir.
anyone wants to participate? The remaining changes, or we will go back to Abhinav.
Sir, I would
Okay.
like to go ahead.
Yeah, Abhinav,
This is
can
Dr. Santosh.
Santosh, yes. How are you, Santosh? Where are you from?
Uh, I'm good. Thank you, sir. I'm from Hyderabad.
Okay. When is your exam?
It's in May,
Very good.
May 22.
Okay. Tell me, speak what is left now. Hematology over respiratory CVS. So what are the immunological changes?
Immunological changes. There is there is reduction in the plasma protein content. The albumin decreases, globulins and fibrinogen increases. So the net, the free fraction of drug is bound to increase
Yeah.
if the drug is principally protein bound. And
Okay, so in immunology, so you have to tell 3 points. Leukocytosis occurs. Okay, it may go up to 9,000, and albumin decreases by 14%, and globulin increases, and total protein decreases. Okay.
Yes.
Good. So, okay. So go back to Abhinav.
Yes, sir.
How are you? Okay, how are you finding?
Good, sir.
You answered well.
Thank you, sir.
No, I'm asking you. You feel like you answered well. You answered it.
No, I need to be a bit more fluent. So
Okay.
probably some more.
No, you were
still.
excellent. But the thing is I never asked to the point, to be specific. Any like maternal physiological changes, just directly go to system wise and tell in a points, bullet points. Okay, because you have a like time limit, right? Okay, so like we are finishing this physiological changes. So let me see. So, as like Abhinav has mentioned about cardiovascular changes, there is a cardiac output rises by 50%, and mainly diastolic BP drops in early pregnancy and reaches at lowest at 20 weeks. Okay, so remaining pulmonary wedge pressure and CVP remain unchanged, and cardiac output rises throughout the liver, peaks after the birth. Okay. And next, you have to tell about this iotocaval syndrome. Okay, this is important. So I think nobody mentioned about this. So gravid uterus resting on the aorta or inferior vena cava causes iotocaval occlusion. So only 10% of the women experience supine hypotension syndrome. So even if a normotensive, supine posture may limit placental blood supply. Okay. So after 20 weeks, you practice left lateral tilt. Okay. And so, yeah, as I mentioned, the diagrams are important for EDAIC Viva. So like, I think Abhinav has drawn the same diagram. Here, I want to stress on one point. Whenever you draw the diagram, the units are important. Okay, and labeling is important. Here, you can take x-axis gestational age in weeks and y-axis percentage change. As we saw in the first trimester, the heart rate increases by 20%, and it increases to 30% in second trimester, but in third trimester, there will be no change. Okay. Then coming to stroke volume, same thing. It increases up to second trimester, and again cardiac output. It's very simple. Just to summarize, if you have a time, just draw the diagram. So it helps in you to like say your answer in a better way. Okay.
So can I ask one thing?
Yes.
So how do we keep on speaking when we are drawing a graph, or because otherwise there will be a very uncomfortable
Yeah.
silence?
So like that, like I feel better draw like this. Like if you take in front of them, if you are giving online exam, take a pen, a paper, and in a pad and draw in front of them. Or else you say hardly it takes 30 seconds. That is okay. I feel that is fine. If there is a pause, no, they'll ask you again. So let's continue like that. So that's fine. You can draw and explain, or draw and later you can explain. Or if you want, you can use whiteboard. It's up to you. In Zoom, there is a whiteboard. It's up to you. So anything for maternal physiology?
The central nervous system changes.
Yeah, tell me. Okay.
Musculoskeletal system.
Musculoskeletal, yeah. What are the ECG changes?
So what happens is because of all this increase in plasma blood volume, cardiac dilatation and hypertrophic takes place. Because of that, there's a slight left axis deviation. During
left axis deviation, ST depression, and T-wave flattening are the physiologically abnormal ECG finding in pregnancy. So again, I was asking about the FRC. So in upright position, it decreases by 20%, and in supine 30%. This is an important question, and they ask you usually. And that's all I have mentioned. And about this partial pressure of carbon dioxide, it is at 4 kilopascals at a term with a compensatory increase in renal bicarbonate excretion. Okay. So again, this is summary of your respiratory changes in a diagram form. Again, x-axis gestational age in weeks and y-axis percentage change. Okay. All right, so we'll go ahead, and other changes include reduced chest wall compliance and reduce partial pressure of carbon dioxide causing mild respiratory alkalosis and increased to 3D-PG shifts, the P50 shifts from 3.5 to 4 kilopascal, and there is increased airway edema and increased breast size may impede intubation. All right. So renal changes, okay. Anyone wants to tell? Yes, Abhinav.
So what happens with the renal system is that there is increase in renal plasma blood flow, and there is by 50%, and there's also an increase in glomerular filtration rate up to 150 ml per minute. Because of this, serum urea and creatinine will fall. There is a net decrease in tubular reabsorption. So because of this, we see glycoseuria and proteinuria.
Yes. And reduce plasma osmolality, increase bicarbonate.
So what happens is there is increase sodium increased sodium and water retention takes place, and because of increased activity of renin-angiotensin aldosterone system, and this leads to a net decrease in plasma osmolality. Yes. Also, progesterone has a smooth muscle relaxant effect, so this will lead to urinary stasis and hence increased risk of UTI, urinary tract infection is there.
Excellent. Okay, so GI changes we discussed already. Intragastric pressure and decrease esophageal sphincter increases the risk of reflux and aspiration. Gastric emptying time is increased during in labor and patient receiving opioids. So it will be raised in liver enzymes, mainly gamma GT, ALT, AST, and LDH, and alkaline phosphatase also increases because of placental production. Gallstones are common, okay, then protein synthesis is reduced. So that's why non-obstetric procedure, cholecystectomy is the, I think, second most common surgery. I think first one is appendectomy, second is a lap chole. Okay. And sorry. Okay, so next, who is next? Go ahead with the next question. Who wants to volunteer? Sudhakar?
Sir.
Yes, unmute yourself and video. Yeah. Okay, Sudhakar, introduce yourself.
Sir, I am Sudhakar, anesthetist, working in Dubai, Aster Hospital.
Very good.
A specialist.
Excellent. Good, good. Okay, when is your exam?
My exam on September, sir.
Okay, so still you have time. Okay. So your question is, what circumstances causes challenges in securing the airway in pregnant patient under general anesthesia?
Sir, pregnant woman has engorgement of upper respiratory tract
Mm.
and edema. This leads to mucosal facility
Mm.
and edema.
Mm.
And these persons having large breast masses.
Okay.
This is difficult intubation cases.
Okay.
And vocal cord edema also may present.
Okay. Go ahead. Go ahead.
Sir.
Okay. No problem. Anyone wants to contribute?
As we mentioned in the beginning that these patients have
Abhinav,
increased
yeah,
oxygen.
Abhinav, I'll come to you later. Anyone?
Sir, I would like to tell
Kritika
Santosh.
raised
This
the
is
hand.
Santosh.
Santosh or Kritika, who raised it first? Okay, we'll come to Kritika later. So first, okay, Santosh, you can go ahead.
Yeah, as Abhinav mentioned, I was about to mention, these patients are at the risk of early desaturation due to the decreased in the functional residual capacity and increased oxygen demand. So we have a pretty narrow window to secure the airway. That's one of the challenges.
That's it. Okay.
That I could add.
Okay. No problem.
Possible to have aspiration also.
Kritika, you can go ahead for next if you want to add some more points.
Yes, sir. I'm Dr. Kritika. I'm from Bangalore.
Very good. Okay. When is your exam?
So my exam is in October.
Okay.
So it is enlarged breasts, and it gives an appearance of a short neck. That makes laryngoscopy a difficult thing. And second most common is panic situation of the obstetrician shouting on the
excellent.
other thing.
Yeah,
that is
excellent.
physiologically.
Yes. Yeah, excellent.
Physiologically more panicky.
Definitely. That also contributes for your morbidity and mortality.
Pressure.
Yeah.
Yes, sir.
Very good. Okay. Anyone wants to say?
Sir, pregnant patients considered as a full stomach patients because of delayed gastric emptying.
Sudhakar, yes, Sudhakar. Yes.
Because of increased gastric acid production, decreased pH, and decreased lower respiratory pressure, there is a possibility of aspiration during general anesthesia. There is also one complication we can expect.
Okay, Dr. Shivi raised the hand. So you can unmute yourself and you can say. Okay. Okay, so we'll go ahead with the next question to Sudhakar.
Sir.
Okay.
Yes, sir.
So sorry, it's all the questions came to one by one. So how may the risk of airway related morbidity and mortality during general anesthesia for a pregnant woman be minimized? So how you minimize the risk? You have mentioned there will be cord edema, there will be engorgement, so there is chances of trauma, and also how you minimize it.
We should prepare the patient by giving only liquid food or patient in a nail per mouth for adequate time.
From when?
And if patient
okay, go ahead.
2 hours for clear water, 4 hours for liquids, and 6 to 8 hours for solid food. And we should, if patient is having short neck, we should some support on the shoulder and neck. We should pre-oxygenate the patient before doing the procedure.
Okay.
And we should arrange all difficult airway equipment like buoy, microblade, and extra sized blades.
So you prepare as the difficult airway.
Yes, sir.
Okay.
And we will call for anesthesia for help if required.
Yeah. Okay. Anyone who may not Minoti. Unmute yourself. Yeah.
Yes. I'm Dr. Minoti. I'm from Mumbai.
Yes.
Uh,
Welcome.
We can.
When is your exam?
My exam is in July.
Very good. Okay, you can go ahead.
We have to keep small size tubes available
Okay.
for intubation because of IMA, we may need smaller size tubes. And we need to pre-oxygenate the patient well.
Yeah. Very good. Next. Anything?
Difficult airway cart.
Okay.
Short stubby hand.
Okay, who raised first? Santosh?
Yes, sir. And the utilization of cricoid pressure while in induction will raise the risk of aspiration. And
all right. So
that's all I can add.
Okay, Kritika, you want to add? Okay, all right. We'll go ahead with the next question. Okay. I'll come to this again. So what are the recommendation or guidelines regarding airway management in pregnant women?
Sir, I don't know this.
You don't know. Abhinav?
I'm not aware of it either, sir, apart from the regular DAS guidelines.
Yeah, tell me there's only. It's nothing different. You can tell the same thing. Yeah, tell me DAS guidelines. Okay, all right. So all of you answered very well. Excellent answers. So let me tell you, so whenever you answer such questions, like what are the challenges or what are the factors, so try to classify your answer first. Always try to classify your answer. Okay, so that you don't miss anything. Like, so when if they ask you what are the factors contributing for airway challenges in pregnant patients, so classify your answer like a patient factor, anesthetic factor, and a theater or a team factor. In patient factor, all of you mentioned about increase obesity, increased BMI, or a large breast. It makes difficult in insertion of laryngoscope. So again, difficult airway. And because of gravid uterus, again, we have seen during GI changes, everything. So that increases the risk of aspiration. Third thing, because of decrease in FRC, so risk of hypoxia. Okay, so these pregnant patients go for desaturation very fast. Okay, and as we mentioned, mucosal edema engorgence causes risk of airway trauma. So these are the patient factors. And when we go for anesthetic factors, like anesthetist factors, like lack of experience in managing obstetric airway, that also contribute to the morbidity. Lack of experience in emergency GYAN LSES, and the failure to check equipment. So that is also important thing. And here only difficult airway, cart preparation, everything comes. And anxiety pressure to deliver a baby causing anesthetist to rush. So that is also, you will not assess the patient and you will not check the equipment because there is a category 1 cesarean section. You have to intubate fast and deliver the baby. That may lead to morbidity, mortality. And poor airway examination, that also contributes. And even poor pre-oxygenation also contributes to morbidity. So someone mentioned about anxiety, so that's also inadequate positioning. And like, because most of the time this emergency LSES will occur in LND OT, this is away from main theater, that also contributes. And lack of understanding from obstetric nurses and neonatal regarding anesthetic priorities. So they want to deliver fast, so they don't like not bothered about airway. So that is the thing. Then again, the trained assistant is very important. Okay, if he's not familiar with all such cases, record pressure may hamper your airway and make it a difficult airway. That might lead to desaturation and hypoxia. All right. So the take-home message is classify your answer. So you can say one point or at least 3 points in your each heading. So your answers are complete. All right, we'll go ahead with next question. So when it comes to what are the factors or what changes you can make to prevent this morbidity and mortality in obstetric patients. So we have to follow the guidelines. So that's important. So regular training of obstetric anesthesiology just in airway skills, including intubation failure simulations, and training how to deal with the failed and inadequate regional techniques, and training of non-anesthetic obstetric staff, and following the difficult airway guidelines. Okay. So then, so again here classification, training and following the guidelines, one heading, another one is patient measures, what measures you want to take, and the third one is theater measures. Okay, so patient measures include like all of you mentioned, antacid prophylaxis like sodium citrate, and they might ask you the dose and all, 30 ml. Okay, and airway examination is very important. So assessing for difficult intubation and ventilation, and should assess for front of neck access also. Then other measures, theater measures, you can take proper positioning of the patient. So if you suspect difficult airway or obese parturient, so prepare the OT table for a ramp or Oxford pillow, and ensure pre-oxygenation. And that's what I was mentioning. The skilled anesthetic assistant is very important. And make sure that you have a special equipment like video laryngoscopy or a difficult airway cart ready. And possibility of waking up patient if failure to secure airway and mother's life not immediately danger. So this is a last step. Then that's it. So this is something called National Audit Project done in UK. So they found the main reasons for complications or airway related morbidity are like first one is poor assessment, like poor airway assessment, poor planning, like not checking the equipments or difficult airway cart ready, and poor failure to plan for failure. And whenever necessary, they like yeah, awake fiber optic intubation was indicated but not used, and repeated attempts which will result in airway trauma and further morbidity. And obesity is a independent risk factor for airway morbidity. And the poor judgments also contributes for your airway mortality and morbidity. All right. Anyone else want to say? Okay, we'll go ahead with the third question. So Dakar, can you come on the screen? Okay, see you.
Yes, sir.
Okay.
Yes, sir.
No, okay. So Dakar, you are done with our third volunteer, Dr. Shivi, over here.
Sir. Yes, sir.
Very good. So introduce yourself, please.
I am Dr. Shivi, working as a specialist anesthetist in Delhi, and I'll be giving exam on July.
Very good, excellent. So for you, the topic is post-dural puncture headache. So what is the differential diagnosis of postpartum headache?
So postpartum headache can be because of various reasons, and they have to be differentiated for the proper management. The postpartum headache can be because of infective causes. It can be because of vascular causes, and it can be because of okay. So in infective causes, it can be meningitis or encephalitis. In vascular causes, there can be CVT, cerebral venous thrombosis. There can be subdural hematoma or intravascular, intracranial hemorrhages, and other vascular causes like migraine and PDPH. And there could be some patient-related factors that may cause headache, like anxiety and tension headache because of some personality traits and because of caffeine withdrawal. So all these have to be differentiated.
Oh, excellent. Okay, this is the way you have to answer. Classify your answer as I was mentioning. Excellent. So we'll go ahead with the next question. Can read the question.
What symptoms in this case would prompt you to assume a serious underlying cause?
Yeah.
Okay. If the patient is having postpartum headache, then what symptoms relates to serious underlying cause?
Yeah.
Okay.
Yeah.
If so yes, so to differentiate the postpartum headache, we have to clinically examine the patient and take the proper history. So if the patient is suggesting severe headache and with no past history of headaches and with neck rigidity, fever, then we should look for infective causes and should be managed.
Excellent. Yeah.
Should be managed accordingly. And if the systems are suggestive of some focal deficit, then there could be intracranial hemorrhages or stroke or CVTs. If the patient is in altered sensorium, also it could be because of CVT. So and it's I guess. Okay. So basically, serious causes are infective and thrombotic or hemorrhagic causes. They have to be dealt immediately and promptly.
Excellent. So anyone wants to contribute? We'll come back to you, Shivi, in a minute. Anyone wants to say? Yeah. Unmute yourself and go ahead.
The type of headache is also important. Patient experiences frontal headache, and it is more on sitting and gets relieved when patient sleeps, lies down supine. So that can also be a differentiating factor.
Okay.
And one of the other causes could be like anxiety. It could be improper sleep, which can lead to headaches.
Like what symptoms you like if you see, then you can suspect there is some serious underlying cause in PDPH patients. As she was mentioning about infective cause like fever with PDPH. So in that way.
Sir, can I say something, sir?
Yeah, who is this?
Indumati.
Yes, go ahead, please.
Sir, any cranial nerve involvement, will that be also accounted as serious, like diplopia, or sometimes they may have vertigo or tinnitus also, which can indicate the eighth nerve involvement?
Yes, excellent. Go ahead.
As mentioned, fever also, sir. We can also take a sepsis screening for the patient. And sometimes even convulsions can be a serious symptom also, sir.
Okay, excellent. So we'll go back to Shivi. So we'll go to next question. Okay. So you identify post-dural puncture headache and schedule an epidural blood patch. Okay. So what are the hazards associated with epidural blood patch?
As epidural blood patch is an invasive measure, as invasive treatment for PDPH, so it is associated with some hazards, like if all the aseptic precautions are not taken during the procedure, it may lead to infections like again arachnoiditis, meningitis, and it may lead to some hemorrhagic complications leading to again subdural hematoma and local hemorrhage during the insertion of the blood patch, and it can lead to headache during the procedure, severe headache and back pain. These are all I do recall.
Okay. Okay, we'll come back to you. Anyone? Someone mentioned projectile vomiting. For what? Okay, anyone wants to?
I think it's for the serious symptoms, sir. Serious underlying cause.
Okay.
Projectile vomiting.
Okay. So anyone wants to say about question third one? C. Hazards associated with epidural blood patch.
Sir, can we mention failure of the procedure? I mean, the patient doesn't get 100% relief.
Definitely.
Yes.
What
So
else?
that's one thing.
Important thing
One
nobody
more
mentioning. Yeah. Sudhakar, Abhina, you want to say something?
Yet another unintentional dural puncture.
Yeah, excellent. That is the important thing. What is the percentage?
I'm not aware of the percentage, sir.
Okay. Excellent. Oh, okay. Excellent, Shivi. Your answers are nice. You prepared very well. Okay. Okay. So I was talking about differential diagnosis of PDPH. So again, classify your answers: non-specific tension headache, migraine, and you can say pregnancy related, like pregnancy into hypertension, preeclampsia and eclampsia. And iatrogenic causes include post-dural puncture headache, and infective causes like meningitis, encephalitis, and sinusitis. And what else? And vascular causes include subarachnoid hemorrhage, cerebral infarction, and cortical vein thrombosis. Yeah, someone mentioned CBT, so try to avoid mentioning the short forms because you are mentioning it first time, right? So tell the complete name. Okay, cortical vein thrombosis. And the space occupying lesions include cerebral tumor and posterior reversible leukoencephalopathy syndrome. Okay. And the second question was, what are the serious underlying cause when you see a PDPH with these symptoms? So if PDPH is associated with hypertension, okay, deranged liver function, if you see, that is also again a serious condition with low platelets, which are indicative of HELP syndrome, and patient PDPH associated with seizures and reduced level of consciousness, reduced TCS, and yeah, as everyone mentioned about infective cause, if it is associated with fever and petechial rash or unilateral headache, and also the focal neurological signs, particularly motor deficits, indicate something significant is happened. Okay, so the last question was what are the hazards of EBP? Again, you have classified general hazards and particular related to epidural blood patch. Okay, temporary or permanent nerve damage. So I was expecting this answer. Okay, temporary and permanent nerve damage, including paralysis, can happen. And again, subdural hematoma can happen, risk of meningitis and arachnoiditis. So further dural tap and worsening of headache. So further dural tap, the risk is around 10%. The chances of dural puncture during epidural blood patch is 10%. And worsening of headache can happen. And the recurrence of headache, that is, you can say failure of epidural blood patch. Yeah, failure or requirement of repeat procedure. So repeat epidural blood patch can be necessary in a few patients. Patient may complain of backache, radicular pain, and bradycardia and seizures. So these are the hazards of epidural blood patch. Excellent. Okay. We are coming to end now. So the maternal physiology and PDPH, all of you answered very well. Excellent. So anything, so if you have any doubts, please post it in WhatsApp group so I can answer it. Okay, anything you want to say? So the pattern of exam and all, we will do it in another class. Okay, so how it is and marks, how the marks are distributed. This mainly in clinical exam, third session, you get these questions. Anything?
So it would be good if any other possible questions that would have been asked also can be mentioned.
Yeah,
what are the other
definitely.
possible questions?
We will do it in next class. Okay, so related.
Okay.
So related to this obstetric and many other other important questions are PPH. They will ask you, and eclampsia, preeclampsia, and labor analgesia is important. And yeah, other than PDPH and this maternal physiology, they can ask. We will do in another class possible questions and the exam pattern exactly, or what, like session 1, session 2, session 3, like that. Okay.
Thank you, sir.
Okay.
Thank you, sir. Thank you.
Thank you, sir.
Welcome.
Thank you, sir.
Okay. Okay, any like if you have any doubt, exam pattern and all, please post it in WhatsApp groups. I'll try to answer it. Okay. Okay, see you next time. Bye-bye.